clinical practice, we're thinking about an individual, and in research, we're thinking about populations of people.
How do you provide breast cancer screening to a group of 50,000 women, and how do you do it in a way that uses your resources the best and has the best outcome? And that's what we do, and that's what we help work towards.
It's that proximity to doctors, to patients, to data that makes this such a rich environment for research.
There are just fabulous and interesting both challenges and problems that are facing healthcare. Probably the most obvious one is the fact that people are living to old age in numbers that have never been seen in the history of humankind. And what we're finding from a person like Adrian is that an active approach to aging is probably a better approach. One of the reasons we think exercise helps is because it restores the integrity of a person's blood vessels, and it makes the brain resistant to the stress of old age and all the things that happen with life.
Diseases like diabetes present a whole different set of challenges, both to patients and to the medical care system.
So Nona, we're going to talk about how your diabetes is doing, right?
Yes, we are.
All right. Well,
From the beginning, our clinical foci have generally been on the common problems, depression certainly being one, diabetes, high blood pressure, low back pain. That led to our development of something called the chronic care model, which began to get some attention, and fortunately generous support from the Robert Wood Johnson Foundation, which allowed us to disseminate it both locally and nationally, and we continue to do that work to the present.
You have come such a long way with your lifestyle changes and changing your eating and exercise.
The advantages that we have at Group Health are phenomenal in the sense that we can do very cost-effective research by being able to pre-identify and target people for enrollment and recruitment in studies, specific people that would benefit from participating in the study and that will further the science.
Certainly all of our best research ideas come from our experience in clinical practice. We learn from what matters to our patients, we learn from what matters to other providers, what the important research questions are. So when I move back and forth between my life on the clinic on the 14th floor and my research office on the 15th floor, I certainly carry the ideas from one place to the other.
Hi.
Hey Nick, I'm David Grossman, pediatrician.
Nice to meet you.
People like to come to Group Health actually to do that kind of work because they can see the value not only in getting the care experience data, but also the cost data linked together and understand the whole picture. So from an integration perspective, it works both for the researchers, but it also really works for the clinicians. And what else do you like to do? Do you like to ride your bike?
Yeah, I love to ride my bike with my dad. We go on big bike rides every Sunday together.
Wow. Yeah. And do you wear a helmet when you ride?
Of course.
All the time?
Mm-hmm.
How about your dad?
Maybe.
We are supported constantly to reevaluate what we're doing for our patients, to say how can we do it better? What could we think of next that would improve the health of our patients? It's not ivory tower academic research that's just going to gather dust in some shelf somewhere. It's constantly saying, how can we maximise the benefit of a new clinical discovery and apply it to as many people as possible? That's really fun.
So I vowed to get my health back and exercise, eat properly.
Habits that, in this case, were changed are a tiny example of the opportunities for us to achieve our mission, really, of transforming healthcare through research, because we're going to forego a lot of healthcare if we can figure out the best ways to change either behaviors or other risks that contribute to diseases down the pike.